Hi, everyone. Thank you for joining today's Policy Round webinar. We're just going to give it a few minutes for folks to join us, and then we'll begin shortly. So hi, everyone, and welcome to today's Policy Round series webinar with Dr. Tracey Rickards. To give you a little bit of background on our presenter today, Tracey Rickards is a recently retired associate professor with the Faculty of Nursing at the University of New Brunswick and the former UNB nurse manager at the Fredericton Downtown Community Health Center. Completing her PhD at Dalhousie University's School of Nursing, Tracey's educational career includes a Bachelor of Nursing in 1986 and a Master of Nursing in 2005 from UNB. Dr. Rickards was awarded a CIHR Embedded Clinician Research Salary Award, a 4-year award to assist her with focusing on transformative research at the Fredericton Downtown Community Health Center. Her research focus is on improving health outcomes for the priority populations. In 2020, Tracey Rickards was awarded $1.5 million for the Healthy Seniors Pilot Project to investigate how best to support seniors to age in place and decrease socialization and loneliness in rural New Brunswick. Dr. Rickards has presented the results of her research at national and international conferences. And in retirement, Tracey will focus on end-of-life care and her role as an end-of-life doula. So the Policy Rounds webinar series was created to enhance knowledge translation of aging and technology research through policy-oriented briefing presentations. So each webinar in the series lasts about 30 minutes, beginning with a short introduction, followed by 15 minutes presentation from our guest speaker, and a 10-minute question period at the end. So the presentation in this series today will provide an overview of a research project led by Dr. Rickards that aimed to explore the added value of foot care provided by an RN with foot care training to older adults in their home. So without further ado, Dr. Rickards, feel free to take over.
Okay. So I'm just going to share my screen. Okay, well, thank you very much for inviting me to talk about this project. It was, we had so much fun doing it, and it didn't really feel like research as much as it felt like just the right thing to be doing. So I'm going to go through and tell you a little bit about the project and some of the things the findings that we found. Okay, so figure out how to advance the slides. There we go. Okay. So to set the stage a little bit and for context, this is a map of Canada that demonstrates the accelerated aging in Atlantic Canada. And you can see the Canada flag on the far left-hand side that says, you know, the average number of people in Canada who are 65 years and older is 19%. So that's an average of all of Canada. But the darker regions, so BC and anything east of Quebec or Quebec and east, have higher than that averages. So in New Brunswick, we have 22.8% of our population is over 65. And by 2038, older adults will account for about 31% of the population, which is a significant jump in elderly people living in New Brunswick. So we have the second highest, Newfoundland has the highest, of the second highest percentage of older adults. 10% of our population are living in, well, 10% of our senior population are living in poverty, 20%, 27% live alone, 47% are living rurally, 93% live in private households. And we have a family income that is one of the lowest in all of Canada. So next slide. Okay. So we're talking about aging, we're talking about diabetes, and we're talking about it as it pertains to a rural setting. So individuals residing in the rural and remote areas facing 2 to 3 times higher chances of amputation due to delayed access and care. That at the present time, 278,000 New Brunswickers are living with diabetes or pre-diabetes. Diabetes contributes to about 70% of all non-traumatic leg and foot amputations. And 85% of those amputations are preceded by a diabetic foot ulcer. So the risk of developing type 2 diabetes increases with age, and we know that. The median age in New Brunswick is 45.7 years right now. But we also know, as I said before, that we have the second highest percentage of elderly people in New Brunswick. 80% of lower extremity amputations related to foot complications can be prevented with the integration of prevention and interdisciplinary care, which I'll talk a little bit more about in a second. In terms of diabetes, we know that every 3 minutes another Canadian is diagnosed with diabetes. In 2020, they estimated that about 13% of the New Brunswick population was living with diabetes. And they also predicted at that time that by 2030, we would have an increase to 17%. However, we've managed to exceed that. In 2022, we had a prevalence of 19%, and they're now predicting that we'll increase to 25% in the next 10 years, which is significant. So the thing about rurality is that the problems that occur as a result of living rurally is that there's often, especially with seniors or older adults, a lack of transportation. They experience a great deal of isolation, and there's a significant shortage of access to accessible primary care providers in rural areas. And so most rural older adults living have experienced or have talked about having food or housing or financial or all of the above insecurities. And so that's, part of the problem with the living rural. So in our project, which was a Healthy Seniors Pilot Project, which was funded by the federal government and then funneled down through the Department of Social Development in the New Brunswick government, we partnered with, I'm with the university, and we partnered with the hospital, the Horizon Health Network, which is the biggest of the 2 networks in New Brunswick. And our objectives were to better understand the needs of seniors wanting to remain at home as they age, to improve diabetic health, foot health among isolated seniors, and to reduce self-reported loneliness and social isolation. And what we did, or how we approached that, was we increased support and access to services for seniors and caregivers in Fredericton and some surrounding areas. We used a multidisciplinary team of nurses and social workers conducting home visits. And we looked at health and safety assessments, including enhanced foot care for seniors. We really used foot care as a tool for, I guess we should back up. We used free foot care because nobody who was a part of our project had to pay for it. We used free foot care as a tool for engagement. Because what we found in the past is that seniors and older adults can be very anxious or reticent about allowing people into their homes. And so, this was one way that we were able to gain access to them. And we also partnered with Mimosa to further field test their Mimosa Pro, which is a device that was used to take interesting pictures, and that assisted the nurses who were performing foot care in making some of the decision-making process around doing the foot care. So a little bit about the study itself. You can see that the study went from November 2020 to December 2022. And yes, that means we started right at the very beginning of COVID. And so, that made us pause for a minute so that we could make sure that we were engaging with the older adults in the safest way possible. And so, we complied with all of the guidelines around safe interactions with people. So our population that we were looking for were seniors, and we used 55 and over for that grouping living in rural New Brunswick. We got our ethics approval from the University of New Brunswick's Ethics Board and the Horizon Health Network Ethics Board. So our care approach, as I've mentioned before, was that we had registered nurses with foot care training and experience with doing foot care. And what they did was they went out to visit the seniors and did 6 visits over approximately a 6-month period, but they went every 4 to 6 weeks, depending on the need. And they performed a foot risk assessment. They performed foot care, and they supported the aging in place, provided support for that. What they did that by providing education about diabetes, if that was relevant, about footwear, about their diet, about some of the medications that they were taking. And so, and just sort of doing a general house assessment and consulting with an occupational therapist if they felt that there was a need for adaptive equipment to improve the safety of the older adult living at home. And then registered social workers also went to visit the older adults, and they visited at baseline, at 3 months, and at 6 months, and then additionally as needed for each individual person. And some of the things that they did was they helped with access to getting resources. And what was noted was that most of the time, older adults didn't have any knowledge of what the resources were that were available to them, had absolutely no knowledge of how to access those resources. Many of them didn't have internet. Many of them didn't own a computer. And so, any of them who'd had tried had noted that the application processes were very cumbersome. The social workers also worked with some of our seniors around housing security, and we had quite a few older adults who were rent-evicted during the time that they were part of our study. And so the social workers really worked hard to find them new housing that was still affordable to them, all of the time when prices for housing were increasing dramatically. So, and the technology, as I mentioned, we were using the Mimosa Pro, which is a great little device that at the time we were using it was a camera that was magnetic to the back of a cell phone. And it took pictures of the foot and wounds, and then we used it for foot and wound care monitoring and for decision making around whether we needed to look for additional consults with specialists. So some of the results that we encountered or that we found was that we were really hoping that we would be able to get 200 seniors who would want to participate. We felt that if we could do that, then our data would have some significance. And we were so impressed and blown away, actually, by the enrollment of 366 seniors. And that's not everybody who called and wanted to enroll. So those are the people who we actually enrolled. Now, of those 366, we completed 313 who completed all of the visits. We lost a couple to death. We lost a couple to hospitalizations not related to their feet. And we disenrolled a few people who, after 3 tries of trying to meet with them, they changed the meeting, or they didn't show up or whatever. We disenrolled people. So the average age of the participants was 75.6 years, and our diabetic prevalence was 44%. We had slightly more women than men. We had 58% women and 42% men. 47% were married, 53% lived alone. So they were either bachelors or widowed or divorced. 60% of our participants had a high school diploma or less. And 45% of them were living at or below the low-income poverty line. So Canada has the lowest rate of high-risk diabetic foot screening among the UK and the US, New Zealand, Australia, and Germany. And in 2007, which is the last time that it was investigated, less than 25% of New Brunswickers the New Brunswick population was receiving the minimal recommended foot care for diabetes, which includes one or more hemoglobin A1C test, a urine test for protein, a dilated eye exam, and a foot exam by a healthcare provider, all within the last year. So our outcomes were that the average foot risk scores decreased after 3 visits compared with baseline, with their foot assessment at baseline, and their anxiety and their depression scores significantly decreased after 3 months compared to baseline. So we were really pleased with that. So this is just a little bit of a taste of what we found. So the case on the left-hand side of your screen is the non-wounded foot. The case on the right side is a diabetic foot with ulcer. So the non-wounded foot is a 79-year-old male with multiple comorbidities, but no chronic foot wounds. And the patient has a history of cerebral vascular accident, arthritis, and venous insufficiency. Throughout all the visits, the mean tissue oxygenation has remained consistently above 70%, and the mean temperature has stayed within a stable range of 27 to 31 degrees Celsius. And those are numbers that we were able to get from the Mimosa Pro. That's what the Mimosa Pro gave us, was the oxygenation, tissue oxygenation, and the temperature. So you can see on the right-hand side, the diabetic foot with ulcer, that hot spot inside the middle of the red is where the ulcer is on the side of this gentleman's foot. So this is a 58-year-old male patient with a diabetic foot ulcer located on the left mid-foot lateral aspect. The treatment protocol included consistent wound debridement and dressing changes, and initially the tissue oxygenation in that wound area was low. So visits 1 through 3 they were still really, really low, but it showed steady improvement moving forward, rising above 20% starting from visit number 4. Tissue oxygenation in the peri-wound area consistently exceeded 50% throughout most visits, and the wound exhibited notable progress, indicating a positive trajectory towards healing. So just a little bit of information about the cost of a diabetic foot ulcer. So hospitalization related to a diabetic foot ulcer runs on average about $22,754. And the cost of a non-diabetic foot ulcer hospitalization costs about $8,350. So it's quite a significant difference. In 2022, diabetes directly cost the New Brunswick healthcare system $110 million. So DFUs, diabetic foot ulcers, become one of Canada's top most costly conditions. So this is just a slide that shows the healing progress. So the initial assessments, you can see there's a number of different cases there, pictures of different feet. And those dark red hot spots are where that we have the problems, all right? And so with the foot care that we did consistently and debridement, so wound debridement, dressing changes, and really good foot care, we were able to show improvements over the time. So increased oxygenation linked to positive healing trajectory. So sufficient tissue perfusion stands as a well-established predictor of wound healing success. And in this study, the increase in oxygenation of the wound in the area was closely linked to positive healing trajectory. Participants were really, really interested in the images of their feet and the implications for what the pictures meant. And every time they were taken, they wanted to know, well, what does that mean? And what is it showing? And so what we found was that in many cases, it led to an increase in motivation on the part of the clients and the participants to comply with all of the things that they needed to do in order to be as healthy as they could be, especially if they were living with diabetes. And they were really pleased to see improvement over time. So that was a really positive aspect of using the Mimosa. So the study impact, so project results demonstrated the value of the Mobile Seniors Wellness Network and that it is a critical program to ensure the healthy aging of rural seniors. It was absolutely clear to us that early intervention was really important. Identifying opportunities for timely treatment. The sooner we could get in, the sooner we could see a wound happening, or or the earlier we could get treatment started, the better off the person was, and the sooner the wound healed. We definitely, as I mentioned earlier, we definitely had some really good patient engagement. The visual feedback promoted a lot of willingness on the part of the seniors to do active self-assessment if that was possible for them to do. And then improved outcomes, so collaborative efforts towards better patient care. We definitely collaborated. As I said, we're using a multidisciplinary team. The nurses, the social workers often talk together about the clients. They consulted with an occupational therapist in some situations, with a dietitian, and in a couple of situations we actually consulted with a respiratory therapist. So all of those things came together to help with looking after the people in our study. So 6% of the people had active diabetic foot ulcers. 6% of our participants had diabetic foot ulcers at the time that they were enrolled in the study, but none were ever hospitalized as a result of that or related to that diabetic foot ulcer. And no new wounds were seen or developed during the study. So in summary, implementing a provincial program based on the Mobile Seniors Wellness Network approach can support older adults to age in place safely with the supports of the registered nurse who is foot care trained and the social worker. Foot care, including personalized education and proactive nursing interventions, is a key component to holistic health outcomes for older adults. Regular diabetic foot screening has the potential to save healthcare resources while increasing quality of life. And now I guess I would be very happy to field any questions that you might have. So I will stop sharing my screen so that you can see a bigger picture of me. And just check the chat because there may be questions in there.
Yes, so I want to thank you, Dr. Rickards, for taking the time to present today and share your research with us. So as she stated, we have about 10 minutes for any questions, so feel free to put them in the Q&A box below, and we'll have Dr. Rickards answer.
While we're waiting for questions, I can certainly say that when we looked at the costs of our project and the costs of the monthly costs that included the foot care supplies and 2 nurses and 2 social workers and the mileage and whatnot, was about $21,000 a month. In comparison, 1 amputation cost the healthcare system $22,000 a month, or $22,000. So has the province rolled out or scaled this program up in the province? No, they have not. And I wish, this is something that I think would be really important that they do. And, I would like to see that happen. We have been offered the chance to present our findings to the government and to establish a program. But we haven't we've been offered the opportunity, but we haven't had the opportunity yet for all kinds of reasons. Yes, thanks, Ellen. We have thought about that as well. And I guess it would depend upon whether EMP wanted to pick this up again, pick this program up. I guess because it was a research project, we had a lot of leeway. So there was a lot of times when the nurses and the social workers spent between 1 and 2 hours with the clients, with the participants. So, there was a lot of teaching and time spent with the seniors, which I think is why we were able to see improvements in their loneliness and isolation scales. But yeah, it's a great idea to sort of partner with other systems or other programs that are already in place. And thank you, Cindy. Um, well, it was really important that registered nurses do the foot care and the social workers work with the clients. You know, we certainly talked about the opportunity that some of the people who we saw would have probably benefited from having some home support workers, but most of them couldn't afford it or didn't have coverage for it, for the use of home support workers. And one of the really frustrating things were that in order to be qualified to get home support workers, they had to have a need for personal care, like so help with bathing, help with toileting, help with those kinds of things. And quite a few of the older adults didn't need that, but they needed help with other things, housework, kitchen, you know, preparing meal preparations, loneliness even. So those were you know, they would definitely, if I were able to create a program, I would certainly include home support workers in the program. But in terms of the foot care and the work that was done, the registered nurses and the social workers were key for that. Wow. Good question, Anna. So what happened was that at the end of the project, there were certain participants who we felt were so fragile and living such a tenuous sort of existence that we actually kept them on beyond the 6 months that they were supposed to be a participant in the research. And at the end of the research, I was able to have one of the nurses who is very good with foot care um, start a clinic, a foot care clinic in the downtown Fredericton clinic. So if people were able to come to the clinic, then we were able to bring on some of those clients, and so their foot care opportunities continued. There was one gentleman who we had worked really hard with. The nurse had worked really hard with him and was really pleased with the progress that was made. Such that he had a big wound when they started. He had a tiny wound when her time was up with him. And then about 3 months later, we went back into the home to take some more pictures of his feet with the Mimosa Pro. And his wound was back to where it was from at the beginning, and that was because nobody had followed through with seeing him, and he didn't follow through with going to see the specialists. Extramural had discharged him because they didn't feel that there was any need to keep him on board. So, you know, that demonstrated to us that how important it was that people be in the home with that client and not discharge them prematurely. Yeah, of course, there's always ways to educate home service personnel to just do a very, you know, a foot assessment. So when they're bathing or helping the clients to have a look at the foot and sort of just take a look at all of the aspects of the foot and see if there are any sort of reddened areas or areas that, you know, look to be problematic, any new scabs or sores. And then the home service personnel can then alert the healthcare provider to, you know, to come out, or the foot care nurse to come out and take a look and make a proper assessment of the situation. But absolutely, you know, it's unfair to ask seniors or older adults to do their own foot assessment because they frequently can't reach their feet or their vision isn't good enough to do the assessment. So to have somebody else do that for them is a really, really good idea. And yes, a recording of the presentation will be made available.
Okay. So I want to thank you again, Dr. Rickards, for your presentation today. And I also want to thank everyone that joined today's webinar series. Um, as asked in the chat, in case you know of anyone that was not able to make today's webinar, or you're interested in rewatching today's presentation or looking through today's slides, we will have it uploaded on our APTA website, as well as our YouTube. So definitely keep an eye out for that. I want to thank you again, Tracey, for joining us today. And I want to thank everyone that joined our webinar as well. And I hope everyone has a great day.
Thanks so much.
Thank you.
Okay. Bye, everybody.